the right. Is that just for classification? Because then it will not be so important just to classify patient. It's very, finding it's important if you can translate it into the clinical practice and then into the treatment of the patient in order to make it a little bit more efficient. And then a very elegant study coming from Leiden, which is a partner of the AutoCure, have tried to answer this question. Is it important, the immunity, the specific immunity against citrulline protein, is that important for the treatment of the patient? And what they have done, they took patients very early, already at the first signs of immune activation into the body, long before they developed full clinical rheumatoid arthritis, and they divided again into two groups. The one having the immunity and the one not having the immunity against citrullinated proteins. They further divided each group, and they started, some of the patients, they started on a treatment, an anti-rheumatic treatment, and in this case was methotrexate. The other part of the patients were started on placebo. They did not receive any treatment. And this has been done both in subtype 1 and subtype 2 of rheumatoid arthritis. And they followed over 30 months, and the outcome was development of clinical evident rheumatoid arthritis. So at the beginning they were just having joint complaints, and they have or not have the immunity. And there were two interesting observations. When you look, again, they are different, they are not the same. If you look on the left panel, where we have the patients having immunity against citrullinated protein, what is the first interesting observation? Here it's the percentage of people developing rheumatoid arthritis. As you may see, after 30 months, more than 90% of the patient will develop rheumatoid arthritis. But if you treat them, if you put a treatment, and in this case it was methotrexate, as said, you will see that you will decrease the number of the patients that will fulfill the criteria for diagnosis of rheumatoid arthritis at 30 months. So you will delay appearance of the disease. What if you have another kind of joint complaint where you do not have immunity against citrullinated protein? Well, it changes a little bit. First of all, if you do not treat the patient, the black line, you still, after 30 months, it's only 60% of the patients that will develop rheumatoid arthritis. So a lower percent of the patients will end up with a rheumatoid arthritis diagnosis. So it's different from, because here a majority were going into rheumatoid arthritis. What happens if you treat? If you treat with methotrexate? Almost nothing. So in this case, most probably you have to find something else to be able to prevent development of this type 2 rheumatoid arthritis. And I think we may say today that AutoCure has made some contributions to the new use of anti-rheumatic drugs. It started, as already showed, in 2000 with use of anti-TNF only late in long-standing disease. We are using now in early rheumatoid arthritis, and we might in the future use it already before, and it's already today used already before the full development of rheumatoid arthritis. And we also think that we have contributed with ideas for maybe future prevention, both primary and secondary. And I think that the kind of prevention is also early and aggressive therapy in order to the disease to disappear from the body. And then also, for example, stop smoking. It is now shown also by collaborators of AutoCure, is published, but that if you stop smoking, you'll have a much better effect of your both methotrexate and anti-TNF therapy, and as compared as if you continue smoking. And most probably, future will show that if you do primary prevention in patients, in individuals, they are not patients, in individuals of high risk of developing rheumatoid arthritis, most probably you will be able to prevent or at least delay disease. And this is not only rheumatoid arthritis. This is true for several other chronic inflammatory disease. Myositis, for example, which is inflammation into the muscle. It's not such a frequent disease as rheumatoid arthritis, and therefore research has been extremely difficult because cohorts that were not enough to draw any conclusion. Due to new collaborative efforts, however, it is today known that we can apply the same scenario. That's it, that environmental factors, most probably different than those that are inducing rheumatoid arthritis, most probably infection, together with specific genetic background, will result in another kind of autoimmunity that would lead to inflammation and destruction into the muscles. And this might seem quite complicated at the beginning, but I think it's a synthesis of what we have done and actually what we have to do into the future. We have here on the x-axis is the time, and then we have the level of the inflammation on the y-axis. And we have different stages of the disease, the period of being healthy, then the period of what we call pre-rheumatoid arthritis, starting with joint complaints, but not having rheumatoid arthritis. Then fulfilling the criteria for the diagnosis early in the disease, and then the long-standing chronic disease. If you do not do anything, the inflammation will progress like this and will lead to chronic destruction. What has been done already from 2000 that you have seen, immunomodulation by any means, by trying to put down the disease, will lead most probably, will lead to remission, but you have to continue the treatment the whole life of the patient, so it's remission by chronic treatment. What we think is that by identifying the subtypes of rheumatoid arthritis that I have talking about, we will be able to do specific immunomodulation, that's it, tailor immunomodulation, to be able to target each specific immune response in each individual, and that most probably will lead to remission with the possibility to have at least some periods of time that will be free of treatment. And for the future, there are signs already today that if you treat extremely early into the disease with very aggressive immunomodulation, you are able to induce remission, and you are able to have patients off the treatment, and then would be in the future the cure by treatment. And if we think now about what I was thinking of the pre-rheumatoid arthritis, to go in and treat and modulate the immune system already before the disease have flourished, then you will most probably by treatment be able to cure by prevention. And to summarize, I think that we may say that autocure is a successful story, and this has been obvious also for the fourth evaluation, done 4-year evaluation of autocure in July 2010. And this is thanks to the solid scientific basis that was there in place already before autocure, and then to the large European collaboration. And of course, nothing is possible without having the patient in the focus and without having commitment to young scientists and professional development. But this is a successful story, but actually it's not a complete story. I think it's just the beginning. I think that we need to continue from here, and for doing that we have to have a sustainable excellence in science, in care and industry. And we really need a lot of money. We need research funding. Why we need this? Because we want to implement what we have found out by our studies in order to make the chronic disease not so chronic any longer. And because we want to be able to detect very early and to prevent, and we want to have lower number of patients, of course. And finally, because we would like to think that this is not only a very specific narrow field, but it's applicable more general in any kind of complex inflammatory chronic diseases. And that's what I was thinking to talk today about, but if you are interested in collaborators, in partners or results, you may access the autocure website. Thank you very much.